Hi guys, it's Dr. Ryan Choi. I'm one of the consultant gastroenterologists in Sydney's University Hospital. I thought I would try something different this week. Yesterday, I was given a task of delivering a presentation to a group of doctors, gastroenterologists, looking at the interesting paper that was published in one of the biggest society for ulcerative colitis and Crohn's disease called ECCO, European Crohn's Colitis Organization, on the dietary management and dietary advice for patients with inflammatory bowel disease like Crohn's disease and ulcerative colitis. And I know there are a lot of things out there in the internet that may not be entirely accurate or evidence-based. I thought it would be a good opportunity to share that talk. The presentation was created for the medical audience, so you might find that there are lots of jargons and difficult to understand if you're not familiar with how to interpret medical studies. But nevertheless, I thought it would be useful to upload it so that you can see how the doctors think when we look at the scientific literature and how we actually use it in clinical practice. And yeah, if you have any comments, let me know. And if you'd like me to go through any particular topic within that presentation, I'll be more than happy to do so. Thanks everyone. Have a lovely day. Thank you very much for the opportunity. I'm very excited to deliver this presentation, mainly because there has never been a guideline like this published in the field of inflammatory bowel disease, which created a significant heterogeneity in how we're providing dietary management for our patients. So hopefully by the end of this talk, I can give you the good overview of recently published ECCO Guideline, which was only published in June this year, and update on what to do with this difficult group of patients. Unfortunately, this document is long. It's almost up to 100 pages, but fortunately for you, I've managed to distill it down to 3 main parts that is most relevant to us. That is, how to use IBD diet as an induction therapy. And secondly, what do we use in terms of maintenance therapy for those who have achieved clinical remission? And thirdly, in special situations such as stricturing Crohn's disease, IBS overlay, and so on. Just for the registrars, this is a brief reminder how we use the level of evidence. So with the consensus statement, you will see EL written throughout the document. That stands for evidence level. So the highest level is of course level 1, which is mainly formed of meta-analysis of homogeneous randomized control trial or RCTs, whereas as you go down the level of evidence, the quality of the evidence gets lower progressively. So for example, level 2 evidence will be mainly consisted of less robust prospective comparative study, whereas level 3 will be consisting of case control studies or retrospective cohort study as an example. And if you go down to level 5, it means that the recommendation is mainly formed of expert opinion and case report and personal observation and so on. So bear that in your mind as we go through this important document. This is the most important part of the consensus document. Inflammatory bowel disease diet is extremely confusing, not only just to our patient, but also to us clinicians. For example, what is the difference between the UCED, EEN, CDED, PEN, and so on? And we all get confused. That's why it's important to get our dietitian who's experienced in inflammatory bowel disease early on in the management of patients, because it is almost practically impossible for patients to go through all the diet by themselves. As a result, the consensus statement states that everyone with inflammatory bowel disease should have access to a dietitian with expertise in inflammatory bowel disease with high level of consensus of 96%. So let us first look at the induction diet therapy in patients with inflammatory bowel disease. What does the evidence really suggest? So for those who are not familiar with what EEN is, it stands for Exclusive Enteral Nutrition, which means that you're replacing effectively all of your food with oral nutritional formula, such as Ensure and Modulant in America, for example. The period usually lasts between 6 to 8 weeks, sometimes longer, but obviously the tolerability is a problem. So the ECCO guidelines suggest that the EEN is effective for the induction of clinical and endoscopic remission in both children and adult population in mild to moderate Crohn's disease. So where does this recommendation come from? In fact, the evidence supporting the induction therapy of using EEN is pretty strong, with multiple meta-analysis as well as the systemic reviews. So this is one such meta-analysis done for the adult population, looking at the efficacy of the exclusive enteral nutrition or EEN in inducing active Crohn's disease into remission. As you can tell from this forest plot, there's clearly benefit in using the EEN as evidenced by significant reduction of Crohn's disease activity index or CDAI by 150 points after the EEN therapy, as well as significant reduction in CRP by 20 points after the therapy, which was statistically significant. In fact, the growing evidence suggests that EEN may be just as effective as corticosteroids. This is in fact meta-analysis comparing the rate of remission between the EEN versus steroids in terms of the efficacy in inducing active mild to moderate Crohn's disease. As you can see from this forest plot, there was no significant difference between those two groups, supporting the idea of using EN as an induction therapy in those with active Crohn's. What about in adult population? So this is systematic review in Cochrane Library, as well as the meta-analysis, looking at the remission rate between the EN versus corticosteroids. As you can see from this table, the remission rate in intention to treat adult studies, the EN was actually less effective compared with the corticosteroids. It is important to highlight that if you actually look at the per protocol analysis, there was no significant difference between the two groups in inducing the active Crohn's disease. So in other words, if adults were able to complete the whole duration of the exclusive enteral nutrition, there was no statistical difference between the efficacy of the EN compared with the corticosteroids. What about the mucosa healing? The data also suggests that the EN can be effective in inducing the mucosa healing, so that is endoscopic healing as well as the histological healing compared with the corticosteroids. This is a sub-study of the meta-analysis published in APNT a couple of years ago, and as you can tell from this forest plot, the EN was actually more efficacious in inducing mucosa healing compared with the corticosteroids. Of course, this is based on small study. Obviously, we need more data, but the initial data is quite encouraging and indeed supporting the use of EN in inducing active Crohn's disease. What about in more complicated Crohn's disease population? So many patients have significant complicating features such as fistulas, strictures, as well as abdominal abscesses. So this was an interesting Chinese study, looked at a small number of patients. All of them had either strictures, fistula, or abdominal abscess in setting of the Crohn's disease. And importantly, none of these patients received corticosteroids. So the authors show that after the 4 weeks of exclusive enteral nutrition, almost 90% of the patient achieved clinical response. And by the end of the 12 weeks of EN therapy, 75% and received a complete clinical remission. So biochemically, there was a significant reduction in CRP, and also a similar finding was seen in endoscopic improvement as well, as this picture demonstrates. For example, before the EN induction, this patient had fistula, which had closed off after 12 weeks of EN, and there was a significant ulcers in the descending colon and ileocecal valve, which all have healed completely after the EN induction, again indicating the use of EN therapy in more complicated disease population as well. So this paper was published some years ago, looking at the efficacy of EN in a group of stricturing Crohn's disease population, where almost 60 patients underwent 12 weeks of EN therapy. And the authors found that at the end of the study, 81.4% achieved the clinical remission, and more than half of the patients achieved radiological remission. This is really important because they also showed that the luminal cross-sectional area has significantly improved, which means it's widened to give more space for the fluids to go through by the end of the induction therapy with EN for 12 weeks. Another question is then, does the EN help with the advanced therapy response rate? And there are gradually building evidence in adult population. And this is a retrospective multi-center study looking at the early Crohn's disease population who were being commenced on anti-TNF therapy or advanced therapy. As you can see from the bar chart, and if you're on advanced therapy alone in this light blue, you're much less likely to achieve clinical remission compared with the group who has received both advanced therapy as well as the exclusive enteral nutrition, which was statistically significant. The impact was already visible at the end of the 16 weeks, and also there was a sustained impact even after the induction with the EN at the year mark at 52 weeks, which is quite impressive. And the effect was also seen in the mucosa healing as well as the clinical remission, as you can see, with quite a big delta value indicating the efficacy of exclusive enteral nutrition. And this is nicely demonstrated in this Kaplan-Meier curve. But of course, the caveat is that these patients all underwent 16 weeks of EN therapy, which is not always practical because that means they have no food for the entirety of 16 weeks, which is quite difficult. So in interim summary, I've shown that the EN could be effective indeed in inducing mild to moderate Crohn's disease. It may be as just effective as corticosteroids in inducing Crohn's disease. I've also shown some data that it may possibly be efficacious for more complicated Crohn's disease, for those with stricturing disease, fistula, and abdominal abscesses. And I've also touched on a couple of studies looking at the fact that the EN may be helpful in augmenting advanced therapy induction response as well. What about in ulcerative colitis? There are substantially less amount of data available in patients with ulcerative colitis. This one particular study looking at the patient with acute severe ulcerative colitis, the authors found that at the end of the EN induction, there was a significant decrease in the rate of steroid failure and CRP and fecal calprotectin as you can see from red boxes highlighted. But unfortunately, there was no significant difference in terms of preventing colectomy rate or response to the rescue medical therapy, which was quite disappointing. In that sense, the ECCO guidelines suggest that the use of EN or partial enteral nutrition as an induction therapy for ulcerative colitis is not recommended. Of course, the EEN has excellent data as I demonstrated in this talk, but one of the biggest challenges for the patient as well as the clinician is that it's extremely hard to tolerate this dietary regime, because imagine having no foods at all and just feeding on Ensure or Modulant for entirety of 6 weeks is extremely difficult. Not just for the purpose of missing the enjoyment of the food, but for many people, having to stick with EN for a long time may significantly impact their social life as well as their psychological well-being. And therefore, as a result, the EN adherence rate is relatively poor, as I will show in subsequent studies. This is where the partial enteral nutrition come in. This means that we can replace a portion of the food or daily nutritional intake with a nutritional supplements, but not the entirety of it. So as an example, the dietitian may prescribe 50% enteral nutrition with the shakes and 50% normal food, and obviously more tolerable for many patients. The ECCO consensus says that the PEN or partial enteral nutrition provided in high volumes could improve the disease activity, although the details of the optimal dose is not clear. But it clearly states that the use of PEN less than 50% component of the enteral nutrition is not recommended for the purpose of Crohn's disease induction. So in other words, the PEN could be considered for Crohn's disease induction if the enteral nutrition aspect is at least 50% or more. And also consensus statement states that the polymeric formulas such as Ensure for EN and PEN are equally effective to elemental or semi-elemental formulas, which is less tasty and should be recommended instead with higher level of consensus. So what does the evidence say about the partial enteral nutrition when it comes down to Crohn's disease induction? There are growing a number of evidence supporting the use of partial enteral nutrition in Crohn's disease induction, and this is one of that study. This was in the pediatric population, looking at a number of patients who underwent either partial enteral nutrition with 50% of enteral nutrition combined with normal food, or exclusive enteral nutrition, or what they termed TEN, total enteral nutrition, and they compare the efficacy when it comes down to the induction of the active Crohn's disease. As you can see from this table highlighted here, both PEN and exclusive enteral nutrition has significantly improved the PCDAI score. So PCDAI score stands for Pediatric Crohn's Disease Activity Index, which is the same as CDAI that we use in other population. As you can see, there was a significant reduction in terms of this PCDAI score in both the partial enteral nutrition as well as the exclusive enteral nutrition, which were both statistically significant. But another key point from this slide is the fact that the EN was perhaps more effective compared with the partial enteral nutrition when it comes down to Crohn's disease induction, which was again statistically significant, which indicates that although the partial enteral nutrition worked well, it may not be as effective as exclusive enteral nutrition. So the next logical question is then, if you increase the proportion of the liquid or the enteral nutrition aspect within the partial enteral nutrition, for example, if you use 80% liquid with the nutrition formula and 20% normal food, does that improve the efficacy of the partial enteral nutrition? Indeed, the data states that it may be the case. So in this single center retrospective study involving more than 40 patients, and all of these patients in the cohort received at least 80% or more of the enteral nutrition in the partial enteral nutrition with only 20% of food in the mixture. And after 4 to 12 weeks of induction therapy, there was a significant reduction in PCDAI score, with almost 90% achieving clinical response and more than 65% achieving clinical remission. But unfortunately, one of the caveats for this study was that the study did not control for the concurrent corticosteroids or the advanced therapy. But nevertheless, it supports that idea. So the next diet to talk about is CDED, which stands for Crohn's Disease Exclusion Diet. So this diet is where the patients are only allowed to have 14 whole foods, including chickens, eggs, rice, bananas, and apples and potatoes. But all the other foods are strictly restricted, and you need to have certain consumption of prescribed food as per the dietitian. So what does the guideline say about the CDED? The ECCO consensus suggests that the Crohn's disease exclusion diet, when it's combined with partial enteral nutrition, is recommended for induction of remission in children and could be considered in adult population with mild to moderate Crohn's disease. And the second statement states that there's an insufficient evidence to support the use of the CDED by itself without the PEN as an induction therapy for Crohn's disease. So in other words, the guidelines suggest that we can consider using the partial enteral nutrition in combination with the Crohn's disease exclusion diet. For example, enteral nutrition 50% with the nutritional shake and supplements, and 50% being the Crohn's disease exclusion diet. But what does the data say? So this was a nice study that was published in Gastroenterology a number of years ago, looking at the efficacy of the Crohn's disease exclusion diet when combined with partial enteral nutrition when it comes down to induction of the active mild to moderate Crohn's disease. The first thing to note here is that this bar chart demonstrates that the partial enteral nutrition combined with the CDED had high rate of adherence to the therapy compared with the exclusive enteral nutrition, which is not surprising because it's more palatable and more tolerable. And importantly, the Crohn's disease exclusion diet, when combined with the partial enteral nutrition, was very effective in reducing fecal calprotectin on average from 3,000 to 1,700 after 6 weeks, and almost down to 700 after 12 weeks of induction therapy with PEN with CDED combined, which was statistically significant, supporting this idea. So that was in pediatric population, but do we have any evidence in adult population? This was an important paper that was published in Nutrients, which is a very respected journal. And this study looks at the efficacy or effectiveness of the partial enteral nutrition when it's combined with Crohn's disease exclusion diet in inducing the active Crohn's disease. And the protocol that they use in terms of the diet in this study was that in between the week 0 to week 6, they were given 50% of enteral nutrition with liquid supplements. And from week 7 to week 12, EN was only 25% of the dietary intake. And as you can see, with that setup, compared with the baseline, there was a significant reduction in Crohn's disease activity index after first follow-up at the end of the 6 weeks, and also the second follow-up at the end of the week 12. And similarly, and there was a significant reduction in fecal calprotectin as well during this period at the first and the second follow-up. So this data indicates that the partial enteral nutrition, when combined with Crohn's disease exclusion diet, may be effective therapy for induction in active Crohn's disease. So this is the summary of the induction part of the inflammatory bowel disease diet. So the consensus guidelines suggest that EN is recommended for Crohn's disease induction, especially mild to moderate Crohn's disease. And it also suggests that we could consider using the partial enteral nutrition plus minus the Crohn's disease exclusion diet for the induction therapy. But unfortunately, Crohn's disease exclusion diet itself without the enteral nutrition is not really recommended. There's certainly insufficient amount of evidence to support this idea. In ulcerative colitis, however, there was no dietary benefit in giving the EN or partial enteral nutrition or Crohn's disease exclusion diet, and therefore is not recommended at this stage by the ECCO consensus guideline. Let's now move on to the maintenance therapy for those patients who achieve the remission, but how do we keep them in remission as long as possible with the dietary therapy? That's the next part of the talk. Let's firstly focus on partial enteral nutrition in terms of maintenance therapy. It states that the partial enteral nutrition could be considered for the maintenance of the remission in Crohn's disease, including as an adjunct therapy to the medical therapy, with the most convincing evidence of efficacy of PEN comprising at least 35% of daily energy requirement filled with enteral therapy. But however, the details of the optimal duration and psychological impact of the long-term PEN is not known, which I agree with. But unfortunately for ulcerative colitis, there's no role for partial enteral nutrition as a maintenance therapy. So there has been several meta-analysis and systematic reviews looking at the efficacy of the partial enteral nutrition for the purpose of maintenance of the remission in Crohn's disease. And this is one of the systemic review looking at the efficacy of the partial enteral nutrition in terms of maintaining the clinical remission. As you can see from the forest plot, the majority of studies favors the use of the partial enteral nutrition in comparison with unrestricted diet, which was statistically significant, and to a degree of the risk ratio of 0.67, meaning that there was a 33% reduction in the risk of the clinical relapse in those patients who has quiescent disease. This is an important study and an interesting one. Another systematic review and meta-analysis looking at the different regimes of the partial enteral nutrition. So as I aforementioned earlier, you can have a variety of different regime within the partial enteral nutrition depending on the proportion of the enteral nutrition that is liquid with the nutritional supplements, where you can have a regime where you have 25% of the ensure combined with 75% of eat whatever you like, or 50-50 and 75 and 25, and so on. But the question is, does that make any difference in terms of success rate of maintaining the remission in Crohn's disease? And the data suggests that indeed they do. So as an example, if the EN components was less than 25%, there was no real benefit in providing partial enteral nutrition compared with a standard diet. But in contrast, once you go beyond 35% and certainly more than 50%, then you start to see the benefit of partial enteral nutrition for the purpose of maintenance therapy. So which indicates that the clinical response in preventing the relapse in quiescent Crohn's disease may be dictated by the proportion of the enteral nutrition you have in your diet. So that forms the basis of the guidelines suggesting the use of at least 35% enteral nutrition component within the partial enteral nutrition when you're considering the induction therapy in Crohn's disease patients. What about using partial enteral nutrition as an adjunct therapy for anti-TNF or any of the advanced therapies? This is data from the meta-analysis, which was published a number of years ago, looking at that very idea. And as you can tell from this forest plot, the pooled analysis suggests that combination therapy with partial enteral nutrition was effective in maintaining the remission in patients with Crohn's disease. So it appears that if you use partial enteral nutrition as a maintenance therapy in combination with the anti-TNF, for example, you tend to keep them longer without the clinical or endoscopic relapse. So the data for the partial enteral nutrition appears pretty good. But what is the problem associated with it? The biggest problem with the partial enteral nutrition is the question of how long do we continue on with the partial enteral nutrition for? Unfortunately, to date, there's no data on optimal duration of the partial enteral nutrition therapy and the kind of psychological impact it can have on our patients, especially in long run, and which again highlight the importance of individualizing the therapy based on the patient in front of you. I'll just briefly touch on ulcerative colitis. There's currently insufficient evidence to recommend partial enteral nutrition for the maintenance of remission of ulcerative colitis, and unfortunately, we don't have much data to support its use in ulcerative colitis population. What about the CDED as a maintenance therapy in Crohn's disease? And the ECCO consensus guidelines suggest that there's insufficient evidence to recommend CDED for the maintenance of remission in Crohn's disease, and certainly no role in ulcerative colitis as well. So where does this recommendation come from? So this was an important open-label pilot randomized trial looking at a small number of patients comparing those who underwent CDED in combination with the partial enteral nutrition versus Crohn's disease exclusion diet only. And as you can see from this bar chart, at the week 6 and week 12 and week 24, and the efficacy of CDED alone was less effective compared with the combination therapy with CDED and partial enteral nutrition, which indicates that although CDED may be effective in maintaining the remission in Crohn's disease patient, it may not as effective as combination therapy with partial enteral nutrition. Now let's switch the gear and move on to more general dietary recommendation. Let's first have a look at the Mediterranean diet. The consensus guidelines say that Mediterranean diet could be considered for the maintenance of the remission in ulcerative colitis as an adjunct to the medical therapy, but there's insufficient evidence to recommend Mediterranean diet for the maintenance of the remission in Crohn's disease. So where does the data come from? So this is a Kaplan-Meier curve. As you can see, having a Mediterranean diet was associated with increased time to relapse and also time to systemic steroid use compared with those patients who had unrestricted diet, which was statistically significant. What about the red and the processed meat? The guidelines suggest that a reduction in the intake of the red and processed meat could be considered for the maintenance of the remission in ulcerative colitis patients. So what's the data say? And there are certainly a number of studies looking at the diets associated with relapse in quiescent ulcerative colitis. And this was a prospective cohort study looking at the variety of different diets. And they found that the red and processed meat was significantly associated with having a relapse in ulcerative colitis patient by more than twofold, as you can see from this odds ratio. And also importantly, and the absolute quantity of the red meat or the processed meat was also relevant as well. So as an example, those patients who had high quantity of the red or the processed meat had even higher risk of developing clinical flare compared with those who had moderate amount of red or processed meat intake. So this data indicates that probably eating reasonable amount of red meat, probably up to 2 times a week, might be appropriate. Whereas if you are having barbecues for more than 4 or 5 times a week, probably is too much, may be harmful, may even increase the risk of developing relapse in ulcerative colitis patient. And in contrast, red meat consumption had no impact in Crohn's disease patient, as you can see from this Kaplan-Meier curve, which was published in Gastroenterology in 2019. So this is the summary of the dietary recommendation in terms of maintenance of the remission in patients with inflammatory bowel disease. So currently, the consensus statement states that the partial enteral nutrition in Crohn's disease patient could be considered, but not Crohn's disease exclusion diet, whether it's combined with the PEN or not. And in ulcerative colitis, nothing really works except for using Mediterranean diet as well as reduction of the red meat in combination with medical therapy. So let us now move on to special situations. And I'll describe briefly 3 particular situations. Firstly, stricture in Crohn's disease, which is not uncommon. Secondly, preoperative management. And thirdly, irritable bowel syndrome overlay. As we know, patients with stricture in Crohn's disease have significant risk of having obstructive symptoms, and the symptom may be subtle. For example, they may get diarrhea because the solid doesn't really pass through the narrow segment of the stricture, but the liquid does. They may develop abdominal pain and nausea before they develop full-on obstructive symptoms such as vomiting. And the low bulking fiber diet has traditionally been used, but this is largely based on mechanism-based reasoning. Unfortunately, we do not have evidence directly comparing the benefit of the low fiber diet, but nevertheless, the consensus guidelines suggest that the diet low in bulking fiber in people with stricture and Crohn's disease is recommended. It may reduce the risk of developing bowel obstructions. What about the preoperative management in Crohn's disease patient waiting for surgery? Well, the guidelines suggest, as you can see from this slide, that the exclusive enteral nutrition, or EN, provided for at least 2 weeks might reduce the inflammatory burden in people with Crohn's disease who are waiting to have surgical intervention, and might even prevent planned surgery by downstaging the disease. And also it states that to reduce the risk of postoperative complication in people with Crohn's disease, provision of preoperative nutrition is strongly recommended, and with most evidence supporting 4 weeks of EN prior to the surgery, and at minimum 10 days if that's not feasible. So this is an important landmark study looking at the impact of EN can have if it's given in preoperative setting. The authors found that the EN used for at least 2 weeks significantly reduced the length of operation required for the Crohn's disease, and importantly, it massively reduced the rate of postoperative complication. And as we know, we're always worried about anastomotic leak and abscesses and collections after the Crohn's disease surgery, and this study nicely demonstrates the impact the preoperative EN can have in preventing postoperative complications. What about the low FODMAP diet? The guidelines states that the low FODMAP diet is not recommended for the maintenance of the remission in Crohn's disease, and there's no evidence to support its use for the maintenance of remission in ulcerative colitis either. But it does have its role. For example, in irritable bowel syndrome overlay, which is not uncommon in patients with inflammatory bowel disease, the consensus statement does support the use of low FODMAP diet in this specific group of population who we have achieved clinical, endoscopic, and histological remission, but nevertheless still have ongoing gastrointestinal symptoms likely associated with irritable bowel syndrome overlay, which is not uncommon. Actually, there are a number of studies demonstrating the benefit of the low FODMAP diet in irritable bowel syndrome patients in the inflammatory bowel disease population, such as this one, which was published in Nutrients. As you can tell from this bar chart, there was a significant reduction in the episode of diarrhea and symptoms of flatulence after the low FODMAP diet adherence in those patients with IBS overlay within the inflammatory bowel disease. So to conclude, I've started with highlighting the fact that it is crucial to involve our dietitian early for malnutrition screening, as well as supporting and guiding the patient through on some of the difficult diet. And with respect to the Crohn's disease, the guidelines suggest that for induction therapy, EN is definitely recommended, with partial enteral nutrition plus minus CDED can be considered in this setting. And for maintenance therapy, partial enteral nutrition could be considered for maintaining patients in remission. And for the preoperative management, EN is recommended for at least 2 weeks. For stricturing disease, low fiber is recommended. In IBS overlay, low FODMAP diet is recommended and could be considered at least. Unfortunately, for ulcerative colitis, not much update other than considering use of Mediterranean diet and reduction in red and processed meat in conjunction with advanced therapy that we use in our patient. With that, I'd like to conclude. Thank you very much for the opportunity.